Dear audience, I would like to present my PhD topic, which I have been working in the last 2 years. My name is Zsuzsanna Domokos. My vision is to develop an interdisciplinary knowledge investigating the association between dental and systemic diseases, and also improve the treatment which involve both dentists and medical doctors. And my mission is to incorporate multidisciplinary attitude into clinical practice based on a comprehensive knowledge. My specific goals in order to fulfill my vision and mission is to try to identify a possible risk population in dentistry through a meta-analysis, and also improve the treatment methods of periodontal patients. The title of my first meta-analysis is Patients with Inflammatory Bowel Diseases Have a Higher Chance of Developing Periodontitis. This manuscript was already published into Frontiers in Medicine journal, which is a Q1 journal. About the background, periodontitis is the most common oral condition in the world. According to different epidemiological studies, it can affect from 20 to 50% of the adult population. However, severe periodontal disease affects 10% of the adult population, which is the major cause for tooth loss. Moreover, periodontitis is not only an oral condition, but it can contribute in developing coronary heart disease, preterm birth, or even stroke, so it can even cause the death of the patients. It is known that there are several risk factors which are associated with periodontitis. Some of the most known are poor oral hygiene and smoking, but there are also systemic diseases like diabetes mellitus and hematologic disorders which are associated with periodontitis. And our main question is that if maybe inflammatory bowel diseases could be also associated. And to thoroughly investigate the topic, we investigated separately if patients with IBD have a higher chance to develop periodontitis, and also the other way around, if patients with periodontitis have a higher chance to develop IBD. As both diseases are multifactorial, investigating the possible association between them could widen our knowledge and also improve the treatment of these diseases in the future. The aim of our study was to investigate the association between periodontitis and IBD from both directions and to try to identify a possible risk population. To answer our following clinical question, we used 2 separate PICOs, and the clinical implication was to identify the risk population. Here is the following search key which we applied, and in the end we ended up with 14 eligible articles. As a primary outcome, we counted odds ratios, which I will show you in this first slide. Here you can see the odds ratio value is 2.65, which means that patients with IBD have a higher chance to develop periodontitis than compared to patients without IBD. We did this evaluation separately for the 2 types of IBD in the case of Crohn's disease patients and also in the case of ulcerative colitis patients, and we can see that in all 3 cases, the results are both statistically significant and have a high clinical relevance that patients with IBD, all types, have a higher chance to develop periodontitis. The main strength is that based on risk of bias assessment, we used high-quality studies. To our best knowledge, this is the first study to investigate the association from both directions. As a limitation, I have to mention that for the other way around association, for our second PACO, we found only 2 eligible articles, so the formal statistical evaluation was not possible. However, both two studies concluded that patients with periodontitis have a higher chance to develop subsequent ulcerative colitis, but not Crohn's disease. And we also plan to do some secondary outcome assessment, but the measurements in the studies were done in a not standardized way, so it was not possible. I have mentioned the conclusion that IBD patients have a higher chance of developing periodontitis than IBD-free patients. Primarily, the treatment of IBD still remains a gastroenterological issue. However, we should emphasize that the treatment should involve an interdisciplinary work, which also involves dentists. Also, IBD diagnosis is a lifelong diagnosis, so patients should be aware of their associated risk factors, and they should be aware that the regular dental checkups are even more important in their case than in the healthy population. As an implication for research, we should investigate this association more thoroughly so we can find some common immunological or genetical pathways, or also some behavioral or environmental risk factors that can improve the treatment in the future. This manuscript was already finished. And now go on to the second topic, which is the association between matrix metalloproteinase 8 and clinical parameters in periodontitis. Periodontal diseases are destructive processes which involve the periodontium, which is the supporting apparatus of the tooth. On the following slides, you can see the clinical parameters of the healthy periodontium, patient with healthy periodontium. Compared to this, on this picture, you can see a patient with gingivitis. The biggest difference is that for probing, we get a bleeding. And compared to this, in the case of periodontitis, we can measure both radiological and clinical attachment loss. In the histological sample of the healthy gingiva, we see no inflammatory cell infiltrates. However, compared to this, only after 4 days of effect, like not brushing one's teeth, the PM and leukocytes appear and the collagenesis happens. However, the clinical signs come only in a later phase, but there is an enzyme, the matrix metalloproteinase 8, and the elevation of this enzyme can be measured. The MMP8 is a collagenelytic enzyme which causes periodontal degeneration. In the active periodontal diseases, the pathological elevation and activation of MMP8 level can be measured. This is reflected in the oral fluids, like the gingival clavicular fluid, which can very easily be measured from the saliva with a non-invasive method. The aim of our study was to compare how the level of MMP8 changes in periodontally healthy patients and in patients with periodontitis, and also compare the reliability of MMP8 level compared to conventional clinical and radiological diagnosis. To answer the clinical questions, we use the PICO and the PFU framework as well to assess our hypothesis is that MMP8 level measurement can be an efficient tool in clinical practice, which can improve or even substitute in the future the conventional clinical periodontal measurement techniques. Our clinical implication was to introduce a novel, simple, and very convenient method into clinical practice. Here is the following search key which was applied, and after the systematic selection, we had 20 eligible articles to answer our main questions. Here are the 20 eligible articles. However, we realized that there were 3 different laboratory techniques, so we separated these methods, and we did the analysis separately, and we investigated that the mean difference between patients with healthy periodontitis and periodontitis, so the level of MMP8 is the difference is both statistically significant and clinically relevant. We also investigated that patients with gingivitis compared to healthy patients, here we can see the mean difference is still statistically significantly different. However, the difference is not as big, and in the case of periodontitis, as we expected. We also compared the 2 different exposed patients, gingivitis patients compared to periodontitis patients, and also here we can see the high difference between these levels. The main strength of our studies that this was the first study to investigate the level of salivary MMP8 level in patients with gingivitis and periodontitis separately. And compared to previous studies, we evaluated the different methods separately. Some of the limitations that there was a high heterogeneity, but we believe this is because of the different populations used in our studies. Also, we drafted to do the evaluation for chairside tests as well, not only for laboratory techniques, as it would be an easy method to use in the clinical practice, but only a very few studies were available for quantitative chairside tests, so more studies are needed to confirm the reliability of these tests. As a conclusion, we can conclude based on our results that salivary MMP8 level measurement technique is a reliable method, and it should be incorporated into routine dental checkup methods. As the salivary MMP8 level elevates even before the clinical signs, so it's a very useful technique to use in dental prevention. And as for research, we should emphasize that chairside techniques are very easy to use, inexpensive, but more studies are needed to assess the reliability before implementing them into clinical practice. The manuscript from this topic was also finished, and we have submitted it to the Journal of Dentistry, which is a D1 journal, and we are waiting for their answer. I would like to highlight some additional activities I made in the last 2 years. My first topic was brought to Semmelweis Symposium as a poster abstract form, and I also take part regularly in conferences to update my knowledge in periodontology. And I would like to thank you for your attention with this quote: "Every mountain top is within reach if you just keep climbing." Thank you.
Congratulations to your really excellent presentation. My question is, do you plan a clinical trial in this topic?
I would say it's under brainstorming. It's a possible option to do a clinical trial to compare IBD patients to non-IBD patients. We know the limitations of the studies, and we could carry out a better clinical investigation.
Thank you.
You bet. Hi, Zsuzsa. Regarding your first result in the forest plot, if you could go to this one time, I think then it's easier to ask. Yes, there. So the last one, the servo, right? It seems like the event rate there is much, much lower. Of course, the total number is also a bit smaller, but still in comparison, it seems very much smaller. Was there something different in this study, or do you know why the event rate is there?
They have a low number of cases. We don't really know the reason. We investigated these studies, but these studies seem very similar to each other, so there is not an exact reason for.
Okay, great. Thank you.
We are at a good plot. So, as I can see, you have very similar confidence and prediction intervals. What are their meanings and why they are so similar? Can you tell me something about this?
Yes, the confidence interval tells us how much we can trust our measurements. As the confidence interval also does not cross the zero line, which is here, it would be 1. So we can conclude that these results are statistically significant. The prediction interval tells that if we carry out a similar study in the future, then we would expect this to fall in this range, which is also very close to our results.
And why are they so similar? Usually prediction interval is much more wider than the confidence interval.
We believe that these studies were very similar, and all the results are very similar. So,
okay, thanks.
Nice presentation. I want to put some question. When do you think it's more important to search? When the patient have a bowel disease, you will search more carefully the periodontitis, or when you have periodontitis, you search more carefully the bowel disease?
I believe the prevalence of IBD is lower than the prevalence of periodontitis, so I would screen the IBD patients. Also, IBD diagnosis needs a bit more cooperation from the patient, so it would be easier to screen them than all patients with periodontitis to screen for IBD.
And when you treat one of the two diseases, it would help to heal the other one. Which direction?
There is data that periodontitis can cause a systemic inflammation, and the systemic inflammation can worsen the IBD-related outcomes. So it can worsen the treatment, also cause a flare-up. So it would be very important to reduce the systemic inflammation and to treat the periodontitis so that the IBD can also be easily treated or managed in a more easier way.
And for the second study, do you go? How you can do the prophylaxis when the metalloprotectin?
Sorry, I just didn't understand the last part.
You can deal with prophylaxis when you find the saliva level higher than expected.
We can see that there is an activation of this enzyme, which causes that there is histologically this gum is not healthy. So we have to do a treatment, do prevention method. In the first phase, just teach the patient how to brush their teeth effectively, so we can prevent the attachment loss coming from periodontitis, which are irreversible processes.
Thank you.
So you have mentioned colitis ulcerosa as well. So how are the connections between the immunological bowel diseases like Crohn or colitis ulcerosa and periodontitis? Because according to the accepted definition or diagnostic definition of periodontitis, it's caused by the flora and the host immune response. So periodontitis most likely not a oral disease.
Yes, there are also immunologic deficiencies in the development of diseases. Like in the discussion parts, we mentioned some of them, like the CD8 and CD4 cells in the ulcerative colitis and the Crohn's disease patients have a deficiency, which can also affect the oral immunologic systems. So there's not, they did not find an exact answer like this protein or this cell would be responsible for this association, but we see that in all diseases there is a discrepancy of immunologic answers.
So we still don't have any clear answer whether it's a cause or a consequence.
Yes, these are not RCTs, so we cannot prove a cause relationship association. We just see that they tend to be associated, and then that's why it will be very important to investigate this association in the future.
So those patients are risk patients anyway. The second study, you have mentioned salivary matrix metalloproteinase 8 level. Salivary or GCF, crevicular fluid?
We chose the salivary. There are lots of studies which investigate the GCF or saliva, but saliva is much easier to measure than the GCF. So that's why we chose the saliva measurement and not the GCF measurement.
But, just advantages, disadvantages. So how can you make sure, especially if you use ELISA method, this matrix metalloproteinase is a human one? Because according to the diagnosis again, it's caused by the oral flora, and many bacteria produce proteolytic enzymes like matrix metalloproteinase. So that's my second question actually about the methodology, which is quantitative versus qualitative. And if it's qualitative, then how do you know it was human?
There was one study which we see that it investigated this, where does this MMP8 come from in the human mouse, and they concluded that most of that comes from the human, so not bacterial MMP8 enzyme, that's not the product of this. So it is reliable to measure the salivary MMP8.
Okay, and the very last one, how about the other members in the family, I mean MMPs?
Yes, this was also a question also in the part when we started these studies, to why not measure, for example, MMP9, or there are other MMPs. But there was also, this was a systematic review which concluded that out of all MMPs, more than 90% belongs to MMP8 in the periodontal diseases. So this has the most clinical relevance to measure this enzyme.
Has periodontitis any correlation with other diseases?
Yes, as I have mentioned, like coronary heart disease, preterm birth, strokes, respiratory diseases. So there are several systematic diseases which seem to be associated with periodontitis. Diabetes mellitus, so not only IBD, this is a new aspect.
Okay, thank you. And I learned that gingivitis is reversible disease. How is possible if this enzyme level is higher as normally? How can be gingivitis reversible?
Because only the elevation of this enzyme is not irreversible. It can be reversed. After there were studies which we investigated the treatment of periodontal patients, so the non-surgical periodontal treatments, and they concluded that after the non-surgical treatments, the level of MMP8 can go back to a normal phase. In the patients of gingivitis 2, just as before, and in the patient of periodontitis, if we reduce the inflammation, then it can go back to a lower level, a bit higher than patients without periodontitis, but they can also get to a lower level.
Okay, but this enzyme can destroy the periodontal ligaments. So this is the cause of my question: how can be reversible in gingivitis, and these enzymes will not destroy these ligaments?
they will, but it takes a lot of time. So we have time if we screen it in an early phase, and then it can go back to a normal level, and it did not cause any irreversible process. So to get an irreversible destruction, it needs many years to develop a periodontitis with irreversible attachment loss.
And my question goes for your first topic. So are you aware of any group in the world searching for periodontitis in bowel disease? Are there any organized programs anywhere?
Not yet. I know about IBD registries, but they do not screen the oral. They do not screen oral measurements in periodontitis. So this is quite a new topic. I found only independent studies which investigated this topic, but as you can see, there are not so many studies.